Here we go. Okay. Welcome, everyone, and thank you for joining us for today's session of frequently asked questions on biomarkers in multiple myeloma. I'm Mary DeRome, Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. Today, I'm joined by Dr. Alexander Lesokhin from the Weill Cornell Medical College and Memorial Sloan Kettering Cancer Center in New York City, and Dr. Joshua Richter of the Tisch Cancer Center and Icahn School of Medicine at Mount Sinai in New York City. We received quite a few questions from patients and caregivers about biomarkers from our previous webinar of a couple of weeks ago and their role in multiple myeloma prognosis and management. So today we're going to try to answer some of these questions. So let's get started. Okay, so we're going to start off talking about standard multiple myeloma biomarkers. Dr. Lesokhin, can you briefly define what a biomarker is for listeners who may not know, and what distinguishes, for example, a diagnostic biomarker from a prognostic or predictive biomarker?
Yeah, so there's a lot in that question, actually. A biomarker is basically a blood or tissue feature that is associated with a clinical situation. So I think the sort of, clearest, if you will, biomarker is having plasma cells in your bone marrow is associated or diagnostic of multiple myeloma. I think there are other biomarkers that are, for example, predictive of a particular outcome. And I think an example of that in myeloma would be something that we use commonly in ISS staging. So like beta-2 microglobulin is something that distinguishes stage 3 versus not stage 3 or stage 1. And those have some prognostic significance when evaluated in the context of the therapies where those biomarkers were developed. In terms of I guess prognostic and predictive is sort of similar. Anyway, I'll leave it to Josh maybe to talk about what the biomarkers are that we commonly use. Or I can address some of that too. You let me know.
That's a lovely segue. Very nice. So Dr. Richter, so what are some of the commonly used biomarkers that have historically been used in diagnosing and monitoring myeloma? And what do they tell us about a patient's disease?
Sure. So, I think as Dr. Lesokhin pointed out perfectly, plasma cells in the bone marrow are one of the ways we define myeloma. But nobody wants bone marrow biopsies constantly to find out how much is in there and what's going on. They are a figurative and literative pain in the butt. So the biomarkers that we tend to use are chemicals that are made by the bad cells. And we actually have a pecking order according to something called the International Myeloma Working Group, of which we're both members and I sit at the kiddie table. And the top biomarker we look for is that M spike in the blood, that monoclonal protein. And that's usually a combination of a heavy chain like an IgG or an IgA with a light chain, a kappa or a lambda, and it gives us an M spike. And we usually look for that in the blood. And typically more of that means the disease is growing. And if it goes down, we're killing the bad cells in the bone marrow that made it. The second ranked is a urine M spike, that looking for that bad protein in the urine. And that's when we give people those giant orange jugs and say, come back in 24 hours and please fill it to the brim. And everybody hates those. And that's the kind of second tier that we look for. But we don't do that as often as we used to because of the third tier, the serum-free light chains. That's that kappa and lambda. We're imagining that our myeloma has pledged a fraternity and we're able to measure the kappa and lambda levels in the blood. Everyone is either a kappa or a lambda myeloma. And again, more of this protein means the disease is growing. If it goes down, it means it's getting better. And for years, they talked about prognostics of non-IgG types or IgA types. And this may have some impact for the precursor disorders like MGUS or smoldering progressing to myeloma. I don't think it really has much of an impact from myeloma nowadays because we have so many other predictors that have a much greater impact than what type of bad protein you make.
Okay, so Dr. Lesokhin, can any of these standard biomarkers indicate who might respond to transplant or to certain therapies at this time? And I think that work is ongoing to try to, ramp up that predictive nature of some of this data, but I think that we're not quite there yet, but we're sort of getting there.
Yeah, so there's been some, iterative evaluation, right, of some of these biomarkers as a way to, again, stage disease. ISS stage is the key feature there, based on, blood biomarkers like beta-2 microglobulin and albumin, which could distinguish, stage 1, 2, or 3 based on a combination of those levels. And would therefore serve as a predictive model of overall outcome in the context of the available therapy at that time. That has now been expanded upon with the addition of the RISS staging, the addition of LDH values, again, a blood marker that can be evaluated, as well as an additional feature that can really only be defined in the bone marrow, looking at the plasma cells, the cytogenetic features. So in terms of, and we'll get into more of that, as we go, but in terms of the blood markers themselves, I would say that there isn't really a feature there that says, oh, this person is or isn't likely to respond to therapy X, Y, or Z, or to transplant. And I think that is one of the main reasons that our, especially our initial treatment approaches are fairly uniform, and fairly being a key word there. There's of course variation, but the idea of induction, consolidation, and then some sort of maintenance, that overall arching treatment approach is fairly uniform.
Yeah.
Can I throw in one little peek towards the future?
You may.
Thank you. So, what Alex and I have talked about so far are the very standard biomarkers. There are some newer ones, something called Soluble BCMA, which we're starting to measure in our patients in clinic. It's not part of the routine list of, okay, you're in a complete remission, partial remission, but we're starting to look at it. And this is an important thing because a lot of the treatments we use, including a very amazing treatment that Dr. Lesokhin was the lead author on the article of elranatamab, which was recently approved, these anti-BCMA therapies. And although we don't have all the nitty-gritty just yet, we know that when this is sky high, people tend not to respond as well, but it doesn't mean you won't. But if it's 0, we do know that there's a small group of people who have a deletion of 16p who they don't express the BCMA, so they're not going to respond to it. So you can theoretically send this test, and if it's 0, or if it's sky high, we don't think you'll respond as well, but it's not the end all be all. So this is more of a peek to the future, not a standard test just yet.
I hadn't heard about that 16p deletion. That's a new one on me.
The location for BCMA, right? So
yeah, this is from a lot of work that was done by Nikhil Munshi and his group up in Boston.
Cool. Interesting. Okay, so Dr. Richter, I know we were just talking with Dr. Lesokhin about getting these cells out of the bone marrow and how it's so important to get those cells so you can do a lot of testing on those cells and look for different biomarkers in myeloma. But we had a couple of patients who wrote in on the webinar that we just had about biomarkers and said that they've had bone marrow biopsies, but they didn't get enough cells out of their marrow to be able to do some of this important testing, like the fluorescent in situ hybridization or FISH, and a lot of that is really interesting genomically, right? To really tell what's happening in your own personal myeloma. So if that happens to a patient, like on your service, so what happens to those patients? How do you then help them? Do you have to give them another biopsy?
Well, so I think Dr. Lesokhin pointed this out perfectly, that right now, for the majority of our decisions, we're not using this information, and we can still provide any therapy choices without this. The problem is once that sample is done, you can't really go back and refish it. So the problem is usually sometime after a bone marrow, people are going on treatment, and the amount of myeloma in their bone marrow is heading towards 0. So repeating a bone marrow biopsy at that time, if there's not a lot of myeloma or no myeloma in there, if there's no bed cells, you're not going to find the abnormalities.
Yeah.
So for patients where we think we're going to need this information at the time of a relapse, where we know that the burden of disease in the marrow is likely to be such that we're likely to find the abnormalities, then we talk about repeating a bone marrow biopsy.
Mm-hmm. Okay, that makes sense. Okay, so we discussed a little about the predictive properties of genetic biomarkers. So Dr. Lesokhin, can you go into a little more detail on what some of those markers might be genomically? And so, for example, what are the high-risk genetic biomarkers, and what are the implications on the presence of those biomarkers for a patient's treatment?
Yeah, so I think this is a field that's continuously evolving, right? Because of the advent of our ability to just sort of sequence the entire cell of the entire genome of a cell, in a few weeks at a reasonable cost, So, but the standard fish, or the things we go fishing for, as Dr. Richter has nicely said, are the things called IGH translocations. So like 414, 1416, and also 1114. So those are important for prognosis. Some are high risk, some are not. I'll get into that in a minute. 17p is another one that is very important. As are abnormalities of the first chromosome, so gain of 1q or amplification of 1q and deletions of 1p. So what are the high-risk features? So traditionally, 414, 1416, and 17p deletion have been considered the high-risk features, and those are the ones that are included in that RISS staging criteria. And they imply a more aggressive phenotype. It's certainly a disease phenotype where individuals will respond to their initial treatment, but these patients tend to recur earlier than those that don't have some of these abnormalities. Now, there's a couple of things about that, because that doesn't necessarily change our approach in terms of initial treatment or initial induction treatment. But it does sort of change our approach when we get into a maintenance phase, because there we understand that patients will have disease recurrence more rapidly than we would want. And there have been several treatment approaches that have been developed to try to prevent early relapse that have shown benefit, namely, rather than lenalidomide maintenance alone, the combination of lenalidomide and proteasome inhibitor-based maintenance approaches. Now, I mentioned also this translocation 1114. It fits, I think, in some ways in its own class because, the drug venetoclax or other BCL2 inhibitors seem to have preferential efficacy in this subset of individuals. And this is not a drug that's currently approved for myeloma, like venetoclax is approved for CLL, but we commonly will use it in individuals with this translocation. So it offers another therapeutic opportunity there. So in that sense, this is predictive of response to venetoclax, going back to that, what's predictive, and so on. Combination of questions there.
Yeah. So I have been seeing a lot more data on combination maintenance therapy, which is interesting, right? So there's a number of patients that we've had on some of our podcasts that we've recorded lately that have been on, these combination maintenance therapies based on their level of risk, which is genetically determined. So it's a kind of interesting and more recent development, I think. So which is cool. Okay, so Dr. Richter, can a patient's genetic biomarkers change over time? So in particular, they're interested in whether they can go from having high-risk biomarkers to not having high-risk biomarkers. And I think that's probably less likely than going from not having high risk to having high risk as disease progresses.
Sure. So can this change? Absolutely. Oftentimes some of these abnormalities, these cytogenetic changes, are part of the spark that may set off the development of myeloma. You tend to carry those through as you go along, but you can certainly acquire new ones. And the most common one to acquire is a gain of 1Q. And as Dr. Lesokhin mentioned, this is unfortunately a higher risk abnormality, and it tends to occur pretty frequently over time. In terms of, can you ever go from high risk to standard risk? I don't really see it that way. I think that we look at patients initially as having high risk or standard risk. And if you look at, our colleagues at the Mayo Clinic have a website, msmart.org, that includes these risk factors of what puts you in high risk or standard. And the only thing different from going from upfront to relapse is a concept of functional high risk. So separate from cytogenetics, if you relapse within 12 months of your initial diagnosis or transplant, they call you high risk. But again, it doesn't mean that you're going to have a poor prognosis. I have many patients that have 17p, 414, 1q that do quite amazing. So unfortunately, you tend to add more onto it. You never really get out of it, but it also doesn't define your disease. And there are a lot of other factors that go in there.
Yeah. So, okay. So in our recent webinar that we had on biomarkers, and that was actually done with the group from Miami. So we had Francesco Mora and Ben Diamond on that particular webinar. And we talked a lot about this new model that they've come up with for prognostication, okay, which is just a research model and is not clinically in use yet, that they call IRMA, which stands for Individualized Risk Model for Multiple Myeloma. So I don't know, Dr. Lesokhin, if you've done any reading about this model or if you know anything about it. But anyway, what are the implications and what can it tell clinicians about their patients' multiple myeloma? And again, I have to stress that this is not in clinical use currently. It's just a model that they've developed, and it will continue to be developed as more data is added to the model.
Yeah. So I appreciate that question. And I some of that data was, developed using the genetics or genomic information, acquired from patients treated at our center as well. So, as well as many other centers around the world. And I also just that Irma, I can't help but think that that sounds like an income-adjusted Medicare payment. That name. So if you Google it, that's what you'll find.
I will do that.
But all that aside, this is a model that is based on targeted sequencing. So let me step back because it's complicated, right? When we do that bone marrow biopsy, we pull out those bad cells, the myeloma cells. We also pull out everything else that's there around the myeloma cells. And there are tools available to isolate the myeloma cells specifically from everything else. And one can look at what everything else is, and that's the microenvironment, right? One can look at the myeloma cells. And these days we can look at those myeloma cells with really fine detail, like these newer ways to evaluate the genomes of those myeloma cells allow us to not only sequence the entire sort of genome, but we can also sequence sort of just like in a targeted way for specific genes we know, or segments of DNA that we know lead to that we know drive cancer development, right? They're called driver or tumor, oncogenes, right?
Right.
And so there are these targeted panels, and then there are the whole genome approaches, and then there are kind of something in between that kind of doesn't look at the whole genome, isn't targeted, but only looks at sort of I will call the accessible genome. And I'm gonna stop there for fear of, getting into like the sounding too much like a textbook. But suffice it to say, when you put all of these together, and then you also look at standard FISH that we've talked about a little bit, and you look at the things that are in ISS stage, and the whole house is on fire. Sorry, I don't know if you can hear the fire truck in my background. We're in New York City. So anyway, so when you put all of that together, what you find is that if you look at it individually, one feature is associated with a certain outcome, and another feature is also associated with another outcome, and it's really hard to integrate all of those.
Yeah,
and so
it's also like looking at patients and what treatments they might respond to best, right? That's also sort of part of that picture, right?
Absolutely, right. And all of these features, any sort of biomarker is going to be dependent on the treatment the individual gets. Like the utility of a biomarker that's predictive or prognostic is it tells you what treatment is going to work or not work. And so any of these prognostic models are going to be highly dependent on what treatment context they're evaluated in. So there's several layers of complexity there. How do you integrate all of that information in a way to kind of remove the, I'm going to call noise, and that's the stuff that kind of goes together, if it's raining outside and it's wet, the two are together. They have to go together, and you have to think of them together. And so when you think about these genetic models and clinical variables that predict for a higher risk of some outcome in the context of some therapy, you need to kind of think what goes separate and what goes together. Okay, so this is a long pre-ramble to sort of say that that what the IRMMA did is they tried to integrate all of these different variables and come up with a prognostic tool that says, hey, if this person got Velcade, then their outcome was going to be X. If they had this particular genetic genotype, I guess, genetic fingerprint, genetic picture, if they had this kind of ISS stage, and so on and so forth. And they characterize a bunch of different groups, and honestly, for most clinicians, and certainly for most patients and for most regular people, it's it's a lot. It's really complex, right?
Yeah, very complex.
So, but it's moving towards the place where we want to go, where we want to look. I mean, it's kind of moving to a place where we can say, okay, we know these features from a patient's, diagnostic presentation. We know their age, we know their ISS stage, we've obtained the genetic panel, right? And that's not something we do routinely, right? So we're not there yet, right? That's why this very much is a research test. We've obtained this genetic panel, and we know that if we use a treatment that uses Velcade, Revlimid, transplant, chronic therapy after that their outcomes based on their combination of genetic and clinical features are going to be, this. And on some level, that theoretically allows us to then say, oh, okay, well, this patient's unlikely to benefit or more likely to benefit from transplant. We should or should not use this. And I think this is, I would say, very avant-garde at this point. But this is definitely a direction. And at this point, it isn't actually, it's all kind of looking backward at treatment that has been delivered thus far, right? It doesn't incorporate newer things like daratumumab. It doesn't actually, right?
Yeah. Because much of this data was collected some time ago, especially all of the data that they used from the COMPASS study, right? And there's not that many patients in that study who were on the more modern therapies, at which time it was like Dara, Darzalex, or, Implicity were really only the more modern things that were in there. So
absolutely,
it has some catching up to do.
And that's the nature of these type of models, is that they're always going to have some catching up to do, but they still teach us on an individual level that, you are more or less likely to achieve a good response with this or that therapy, right? And I think it's similar to what we do now. Like, we know if someone has 414 translocation 414, we know that a proteasome inhibitor is important to add into their therapy. We know if someone has an 1114 translocation, that venetoclax is going to be very useful for their treatment. Similarly, these types of models need to be looked at, prospectively, because that 414 and 1114 data and information comes from studies where folks looked at these translocations and realized that these are the folks that benefit from this type of therapy. And so the IRMMA is a move to sort of create a fingerprint that we can then look at and say, okay, based on this fingerprint, we can give treatment A or B or C and look and see what happens there.
Yeah. So it's cool though. So, I mean, they have a lot of patients' data already in there, and they're asking doctors and researchers to add as much data as possible to the model, because it's a really what they call, a machine learning model, right? The more data you put in, the better it gets at predicting, right? So I think, eventually, who knows how long it will take, but I mean, this, I think, is one of the ways that myeloma may someday be cured from this kind of thing, right? Or at least patients will take medicines and treatments that they know are going to work for patients based on their fingerprint and based on the data from this model. So we're not there yet, but we'll get there eventually, I think, from things like this. So it's really pretty interesting stuff. So
I think that's the key point right there. And I'm sorry to sort of cut you off there, but I think that the idea here is that you can try to optimize who needs what therapy for how long, because that's really the goal. When as physicians, when we are treating patients, is how can we use this information to really define treatment. We're not there yet, but not with this and not with so granularly, but we're making strides.
So I think we'll eventually get there. It'll take some time, but I mean, it's big for quality of life for patients, right? That they're not going to be treated with something that is not going to work for them, right? Which happens sometimes, now. So, hopefully we'll get away from that. The more data we have about what works for which patients and why, based on their genetics, I think. So, because myeloma is just different in every person. This is sort of the way that it has to be done. So. Okay, so moving on a little bit. So Dr. Richter, when a patient has high risk biomarkers, does it have implications for the doctor with what they should be treated by? So it's like, risk-based treatment for patients. And how does a patient go about finding a doctor to treat high risk if they are defined as being a high risk patient?
So I'll take the second part first. Anyone who treats myeloma or specializes in myeloma treats all types. I think this is where we would differ from OBGYN, where in fact they have a clear delineation of high risk obstetrics and standard risk obstetrics in terms of who treats them. If we all treat myeloma, we treat high risk just the same. In terms of how does it drive treatment decisions, I think the broad swath, Alex said perfectly, we don't have clear guidelines, but we're starting to chip away at that. And we have a couple inklings of it. And one of the really great studies done recently was done by a colleague of ours, Luciano Costa, who did a trial called the Master trial. And he looked at an induction regimen of DARA, KRD, and, transplant, consolidation, maintenance. And he looked at people in terms of, he would stop them if they were MRD negative. But then he looked back and said, all right, well, what did this look like if you had no high-risk cytogenetic abnormalities, 1 or 2 or more? And, one of the things that's come out of this so far is that the people with 2 or more, you probably need to keep your foot on the gas pedal. Exactly as we've talked about. They may need more than just Revlimid. They may need DARA and Revlimid or proteasome inhibitor and Revlimid to keep things going. But what was interesting is that the 0 and 1 high-risk cytogenetic abnormality group behaved fairly similarly. Not 100%, but they were very, very close on the lines. And it may be that we're starting to figure out high cytogenetic people may need a little bit more, but standard or even 1 high-risk cytogenetic may need less, as in you may be able to stop maintenance. Or if you're MRD negative and you're standard risk with induction, do you really need transplant? And I think, just with anything in myeloma, we can find 10 doctors to give us 12 opinions and argue over what this means. But I think these are questions that we're on the precipice of having real data to drive decisions.
Yeah, agreed. So, and like the more that I talk to patients on these podcast episodes that we're doing, the more I'm seeing patients, right, who, they have they're diagnosed, they go through their induction, then they have their transplant, then they're on maintenance, and they're on maintenance for a couple of years, and they have, long-term MRD negativity, and they just say to their doctor, I'm done. I'm not going to take any more. They discuss this with their care teams, and this is my decision. I really don't want to have any more therapy. I will continue to be watched closely just to make sure that if I start to relapse, it'll be caught early, right? So I think a lot of patients are doing that now.
And I think there's a wonderful study being led by Amrita Krishnan over at City of Hope, SWOG 1803, but it goes by the cooler name, the Dramatic Study. And it's one of the fastest accruing phase 3 studies in myeloma history. And she's looking at people after transplant to be randomized to Rev alone or Dara and Rev, and she has MRD stopping rules along the way. Nice. So it'll probably take us about 3 to 5 years until we start getting meaningful information from it. But this is one of the big steps towards understanding, all the studies up till now say if you do 2 years versus stay on maintenance, staying on is better. 3 years versus just stay on it better. But now with these powerful techniques, we may really get granular, saying, no, if you have this risk and this level of depth or MRD negativity, you may be able to stop. So crossing fingers for that data.
Yeah. Agree. Okay, so now we're going to talk about one of the newer biomarkers on the block over the past few years. We've already just mentioned minimal residual disease, or MRD, in the myeloma world. So, Dr. Lesokhin, can you briefly explain what MRD is and what it means when a result comes back as MRD negative at a level of 10 to the minus 4th, 10 to the minus 5th, 10 to the minus 6th? These numbers are kind of tossed around, and patients sort of don't understand what that means. So and is an MRD negative result the same result as, below the limit of detection?
So I'll take the very first. Can I briefly speak about something? And I'm not so sure I can. Yeah. So and
you can. We know you can do it.
and then the last part of your question. Is it below the limit of detection? And the answer is yes, using that particular assay. Now, in the middle part, you're asking about 10 to the minus 4, 10 to the minus 5, 10 to the minus 6. And really what this is doing, again, this is a bone marrow-based test at the current time where, the liquid portion of the bone marrow is evaluated using either, historically something called a PCR test, not something we do now. Which had that lower sensitivity threshold, 10 to the minus 4. A flow-based test, so that's using something where, there's like a special machine that looks at what's displayed on the surface of myeloma cells and can differentiate myeloma cells from normal plasma cells, the cells they derive from, or from other cell types, and can identify those abnormal cell types, typically at a threshold of 10 to the minus 5. And then 10 to the minus 6 is a threshold that's defined using these genetic approaches where the entire sequence of the specific antibody that myeloma cell is making is looked at. Now, for that last test, as well as for the PCR test, you need to know what you're looking for. So you need to first identify that specific sequence. So you can only really do those kinds of tests if you have a diagnostic sample where that clone was identified. But those are sort of the most sensitive MRD tests that we have, those sequencing-based tests. And the flow cytometry test doesn't require the prior diagnostic specimen. Anyway, suffice it to say that 10 to the minus 5 is sort of the currently accepted sort of criteria for MRD negativity by the IMWG, sort of the international working group that defines these biomarkers. And all of us sort of have an understanding that 10 to the minus 6 is probably better. right?
Mhm.
So, and studies looking at 10 to the minus 5, like the MASTER trial, are able to say, okay, if we have below the limit of detection, once, or we have below the limit of detection on 2 consecutive tests, then, we're sort of, we have a sustained minimal residual disease response, then, those folks will achieve a better outcome. Now, did you say I should be brief? Sorry. So MRD negativity.
We got plenty of time. Just take your time.
So MRD negativity, right? So like at the 10 to the minus 5 level has been evaluated across several clinical trials, and consistently those that achieve that endpoint fare better than those that don't, in sort of the retrogoggle scope kind of way that these things are analyzed, because we took a population, we gave them a fixed treatment, and we said how many achieved that endpoint. The ones that got there did better than the ones that didn't.
Right.
We also know now that if we look at that consecutively 12 months apart, those 2 tests at least 12 months apart, and there's some variability in terms of whether 6 months is enough or 12 months, but whatever, 2 consecutive tests at least 12 months apart, we would define as sustained MRD negativity. And that's probably what we now consider to be the best sort of prognostic outcome, or the best outcome group in response to any particular treatment, those that achieve that sustained MRD negativity endpoint. I think what we now are starting to do, as Dr. Richter has alluded to, is to try to use this biomarker as a way to evaluate, can we stop a treatment or should we add a treatment, for example. And those kind of studies are, as you've heard, ongoing. And I would just, put in a shameless plug for a study that one of my colleagues at MSK, Neha Korde, is running, where we are actually looking at MRD negativity in the context of maintenance therapy as potentially a biomarker that we can use in association with other biomarkers, as well as a feature to stop maintenance therapy with careful subsequent observation. Something you sort of alluded to is something that we should try to do. This is a trial that we are currently accruing.
Interesting. Okay. So, Dr. Richter, so who should be having MRD testing? Is this like every patient, or just like some patients at some points of their therapy? It's not really being routinely used to guide clinical practice at this time, right? Although I think there are some physicians who have a lot of experience with MRD who are kind of doing that, right? But, in the main, there really aren't any guidelines, per se, of what to do with MRD results at this time. So people are, in a way, is a little bit of the seat of the pants stuff. But I think we will at some point get to where there are guidelines, regarding MRD and treatment, and when to change treatment based on MRD, whether to stop maintenance based on MRD, right? So, and is that really being done more in like the big academic medical centers, or more like, or is it being done in the community like at all?
So I think MRD is being a lot more utilized in academia. I there's a spectrum of doctors, and even the myeloma centers, who do it multiple times a year on every patient and use it to inform decisions. There are people, I tend to be more towards the other, which is I use it as little as possible. I think it's a piece of the puzzle. It's not necessarily the main driver of it, at least for me. I think the bigger question is, there's a very, very basic medical precept that we all learn in training, which is, if you're going to send a test, will it change what you do? If the answer is no, do you really need to send it? So if I have a discussion with a patient up front, and we discuss that based on risk cytogenetics and lifestyle and disease, and all the above, that we're going to do a transplant or not, I don't need a bone marrow to guide that decision if we've already made that decision. If somebody's on maintenance therapy and they're just not tolerating it despite dose reductions and supportive care, I don't need a bone marrow to tell me that we haven't found any cells to justify stopping it.
Mhm.
I think that it's part of a discussion, like it's part of a complete breakfast. I think if you have somebody who's on the fence about transplant and their standard risk and they want to know, are they MRD negative? Because that would push them away from a transplant up front or push them towards, we can absolutely do it. So I think doing it at inflection points, or the discussion of doing it at inflection points, such as at presumed complete remission or presumed relapse, if it's going to impact your decision making, you should do it. My concern about doing it haphazardly is that I have a lot of patients post transplant on maintenance that we do a bone marrow and we find 3 cells out of 10 million, and it's upsetting. They're still going to do amazing. There's no reason why they won't do amazing, but finding out that your PET scan is negative, your M spike is 0, your light chains are normal, the bone marrow looks negative, everyone cheering, and like, wait, hold on, we found 3 bad cells, and it's not going to change anything, but that's an upsetting thing to sit in the back of the head. So I am a little away from doing as much MRD as some of my other colleagues.
Mhm.
Can I add to that?
You may.
Please.
Because I agree with the precept that, if you're not going to change your management based on a test, then don't do the test. And I also would say that MRD is a very important test, but it's not yet a test that we can use to say, oh, should you change to therapy A, B, C, or D. That is my current thinking. I think it's a very important test to study and to utilize in our clinical studies to try to understand, can we do that, and when can we do that? Particularly since right now we treat all our patients, as soon as we start treatment, it's lifelong, it's indefinite. Is that really necessary? Can we stop?
I mean, that's the question, right? Mm-hmm.
Yeah, but I would also say it's a piece of the puzzle. There's more to it. And there are other biomarkers and other things that are incompletely explored as of yet that can predict whether or not, someone may have a durable remission or a disease recurrence that are not focused on the plasma cell, right? That are focused a little bit on the microenvironment and other, dare I say, the microbiome and other things like that may also impact how folks do overall.
Yeah. Okay. That makes sense. Okay. And I think we already talked about this next question. So I'll move on to new and emerging biomarkers. Okay, so some data has been emerging on the use of peripheral blood and mass spectrometry, or mass spec as they call it, as a possible alternative to current methods of sampling from a bone marrow biopsy. This seems like good news for patients who, often they're like, that bone marrow biopsy is never anybody's favorite thing to do, right? So Dr. Richter, can you discuss where the state of the science is on this and how close is it being to use clinically? I mean, we're going to talk about a number of presentations that took place at ASH this year that I found fascinating about these new biomarkers and exactly what they meant. So please expound.
Sure. So mass spec is a really cool technology, and it allows us to do a number of things besides just finding, small amounts of disease in the blood. It also lets us know what that is. And what I mean by that is you can't turn on the television nowadays without seeing commercials for some drug ending in mab, mab, for all different types of diseases, rheumatologic, dermatologic, GI, list goes on and on. Any mab drug is a monoclonal antibody. And pretty much all of these are IgG kappa monoclonal antibodies. And the most common type of myeloma is IgG kappa. And if you send immunofixation and SPEPs on people getting these type of antibody therapies for dermatologic and rheumatologic disease, you find an M spike. And then they get referred to a cancer center, and that can be concerning. But one of the great things is that because these drugs, we know what their chemical makeup is and their chemical weight, and you can use mass spec. And Mayo Clinic has been doing this for some time. They're one of the big proponents of this technology. They get a referral for an M spike. They'll send this technology and say, no, this is your infliximab that's being used to treat your rheumatologic disease. It's not a distinct paraprotein, nothing to worry about. So there's some really nice little caveats to get with this. And I believe Mayo Clinic Labs, which is one of the main third-party major centers for sending laboratory studies, have actually converted their SPEC technology to a mass spec-like technology to give finer detail. I think that happened within the last few weeks, if I'm not mistaken.
Wow.
And then there's I think it has the name QMPSS. It's got a big fancy name. And there's a commercial one out there that's being advertised a lot, M something or other. Please fill my brain blanks if you can remember the name of it. But, so these tests are wonderful. But the long and the short of it is that we have so much data with the standard evaluations. We don't know yet for these tests what, if it goes up a little bit, what that really means. If it goes down a little bit, what that really means. We have no standardization to define response, relapse, depth of response. So these are good adjunctive tools, but as Dr. Lesokhin pointed out, we need, in my mind, more prospective data with these to figure out how we can incorporate them on a day-to-day basis.
Yeah, agreed. Okay, so maybe speaking about some of this data from ASH, indicated biomarkers may be able to predict outcomes from CAR T cell therapies, including treatment response and toxicity. I mean, we talked already a little bit about soluble BCMA, which is one of the biomarkers of that, right? So, so Dr. Richter, can you summarize some of this other data that was in some of these abstracts?
Sure. So, CAR Ts are some of the most exciting therapies that we have. And next week is one of the biggest meeting days of myeloma in history, the ODAC meeting next Friday, where both Abecma and Carvykti will be presented to the FDA, one in the morning, one in the afternoon, to try to convince the FDA that we ought to be able to use these in earlier lines of therapy. So there's a good likelihood that by April, we're going to start giving people CAR T cell therapy at first relapse. So the question is, who is going to do better, who's going to do worse, and who's going to have some of the big side effects? And there are a number of really cool presentations at ASH, including Dr. Pan, who is one of our fellows, who is going to be joining Dr. Martin and Dr. Chari and Dr. Wolf and the whole gang at UCSF this coming July. And he looked at the inflammatory biomarkers prior to going into CAR T, basically saying if you had elevated levels of fibrinogen and ferritin, these markers that our body cranks up when we're inflamed, that may predict for worse outcomes on the other end of CAR T, and higher baseline CRP, C-reactive proteins, these inflammatory markers. Also looked at the lymphocyte level in the blood, and higher lymphocyte levels in the blood may predict for some other toxicities that we call Icahns, the immune effector cell associated neurotoxicity syndrome. And there are a few other great presentations by Dr. Zhao and Dr. Hansen looking at other predictors on the back end for who will have longer cytopenias. So people going into CAR Ts who had more myeloma tend to have longer cytopenias, low blood counts after. And we do know that there are a number of patients who the count stays so low for so long, we have to give them back some of those original stem cells that we collected up front many years prior. Those are really the main ones that they found. Also looking into the presence of extramedullary disease, that if you have the kind of big solid masses of myeloma, you tended not to do quite as well with CAR T. So we're looking into ways to kind of, at the end of the day, it's all Goldilocks. We don't want the porridge hot or too cold. So looking ways that if the porridge is too hot, to cool it off before you go into CAR T.
Yeah, makes sense. Okay, so also there were some abstracts at ASH suggesting that markers of T cell health can predict outcomes with BCMA targeted bispecific antibody teclistamab. So Dr. Lesokhin, are the results of those studies likely to result in biomarker testing that will be used to predict treatment response to bispecifics?
In the future, I would hope so. But I think that these data that were presented are certainly encouraging in that they highlight features that suggest somebody might respond versus somebody who is less likely to respond, and also potential ways that one may try to overcome that lack of response as well, right? So one abstract, which was an analysis of patients that we actually treated as soon as teclistamab came out at our center, and then obtained their peripheral blood and did flow cytometry. This is the kind of testing I was referring to earlier, where you look at what's displayed on particular cell populations that are circulating in the blood, and based on what things display, you can identify what kind of cell it is. And this was focused on the T cells, understandably, because this is a T cell directed therapy. This is work done by really an excellent fellow at our place, Ross Firestone. And what he found was that folks that respond tend to have T cells that have more of these kind of like effector molecules on them. So these are T cells that have already seen like a target. We don't know what that target is, but they've seen a target, they've gotten activated, and they're just ready, and they have all of the machinery ready to kill something. And having those cells around at a higher frequency, logically makes sense. Those cells that have all that machinery to go kill something can then, when they're redirected towards the myeloma cell and licensed to kill, if you will, then they do it, and people get a response, right? And then conversely, folks that have a population of cells that typically are like, hey, hold on, chill, we don't want to get activated, and these are called Treg cells. Those folks were less likely to respond, and there were particular markers on those Tregs, one of them being TIGIT, for which there are drugs out there, the checkpoint blockade drugs that are available to block those molecules, and would suggest the possibility that maybe that's a rational combination partner, at least in some ways, with something like teclistamab or another bispecific, perhaps. So that's one story, and there's also another set of work that was based on the Majestic 1 trial, sort of correlative analysis run by Niels van den Donk. And there, they also looked at the T cells, again, looking at what the T cells expressed in the blood and what they expressed in the bone marrow, both at the time that treatment was started and then, sequentially, and then also at relapse. And what they found were that dynamic changes in how T cells behave seemed to be predictive of whether or not folks would respond or not. So if someone had transient activation, they looked at this molecule CD38. Well, we've heard of that one before. And if it went up, and that's a marker of T cell activation, if it went up and then came back down, that suggested that there was efficacy and response and then less sort of ongoing activation. Whereas if the cells go up and then continue to stay up and then accumulate markers of what's termed exhaustion or basically chronic activation, then those folks were less likely to achieve a durable response. And again, from a T cell biology perspective, this sort of makes sense. T cells are designed to go out, do their business, and chill and relax. But if they are chronically active, that means they're ineffective initially, they're somehow unable to get rid of what they're targeted against, then they stay chronically active, and there are other mechanisms intrinsic to the T cells to not, to keep them from doing harm, essentially, and that block their efficacy. And cancers like myeloma utilize those things to be like, hey, yo, I'm cool, I want to hang out here. Yeah.
You can just see the T cells in there talking to each other, right?
Well, they do. That's what cytokines are and chemokines.
Yeah, with words, right? Exactly.
Yeah.
Okay, so I'm just going to have some final thoughts here to wrap up. So, Dr. Lesokhin, what is the most important thing for patients to take away about biomarkers and multiple myeloma? I think it's from my perspective, I just think that it's something it's a developing story, and it's only going to help, I think.
Yeah, I completely agree with that. I think the fundamental take-home message is talk to your doctor, because this is a highly complicated. It's an evolving field, and these sort of biomarkers all need to, including cytogenetics, including ISS stage, and including all the newer testing that we've sort of touched on, MRD as well. All of that, needs to be put into context of what's your treatment. How are you doing on the treatment? What's, how well have you responded so far? Are you tolerating the treatment? All of that needs to be put together to formulate a personalized treatment plan for every individual. And these biomarkers help, but they don't define anyone. Having high-risk cytogenetics doesn't mean automatically that you're going to do badly. These are statistical, kind of like the chances are X or Y, or X-ish and Y-ish is probably the better way to describe it. So I think that's the fundamental message. There's a lot of information that your doctor has. Ask them.
Okay, good idea. Okay, so Dr. Richter, the final word. If you were to look into your crystal ball and try to predict what exciting developments that might be in the future for biomarkers in multiple myeloma, what's next?
The future is saying no to the needle. Right now, we still glean some of the most potent information from the bone marrow. And, because myeloma cells in general don't like to hang out in the blood too often. Some of them go out to take a peek, but most of them stay in the marrow. But thanks to evolving technologies, including mass spec, including next-gen sequencing, including soluble BCMA, we're starting to be able to put together a better picture from the blood alone. And, I can envision a time where bone marrows are not a routine phenomenon. We are not there yet. But I think we are getting closer and closer to having the type of technology that would allow us to do away with them on a regular basis. So that's deep in my crystal ball.
Great. I mean, that's good news for patients, right? So, it's always amazing for me to think about how much the science of multiple myeloma has really advanced in just such a short period of time, right? I mean, 10 years ago when I, joined the foundation and started, working in this area, we didn't have any of these things, right? And now there's just so much to talk about, right? So I think it's great. It's very hopeful. And there's just a lot of really good things coming, I think, as the science continues to develop. So on behalf of the MMRF, I'd like to thank Dr. Lesokhin and Dr. Richter for joining me today. I'd like to thank everybody for taking some time out of their day to join us on this program. Finally, I'd like to thank our sponsors, 2seventy Bio, AbbVie, Adaptive Biotechnologies, Baxter, BMS, Cure, GSK, Johnson & Johnson, Karyopharm, Pfizer, Regeneron, Sanofi, and Takeda Oncology for their sponsorship of this session. And if you have any additional questions about what you may have heard today, please don't hesitate to call our MMRF Patient Navigation Center. Their number is 1-888-841-6673. Thank you and enjoy the rest of your day.